Welcome again, everyone, to today's webinar. My name is Daniela Labate, and I work for IAFRS, and we are one of the MCTAC Plus partners. So we just wanted to thank all of you for joining us today in our first webinar in the Solutions That Work series. So this series, it will be 3 webinars that are going to take place once a month. They'll be the same format as today's presentation, where you'll hear from leading innovators in the field, and then we'll have a panel discussion on the topic. So that said, we're going to go ahead and get started. Today's presentation is focused on innovations in the value equation. Slides are not. There. Okay. So I wanted to remind everyone a couple of housekeeping things. Today's webinar is being recorded. You can access that recording usually in about 4 hours through the MCTAC or CTAC website. And sometime at the end of the webinar for questions and answers, we do encourage you to use the chat box feature and type your questions throughout the presentation to all panelists so that we can see them. And just as a reminder, the information that you received today is current as of today's date. Our MCTAC and CTAC partner slide. The Adult MCTAC Plus part slide. And as MCTAC Plus partners, we work together to provide individualized and hands-on training and technical assistance to adult behavioral health providers throughout New York State on successful transition to Medicaid managed care. So as earlier, this is the first in the series of 3 webinars. We have a second webinar scheduled for October 23rd on access and engagement, and the third is November 29th on integrating behavioral and primary health care. So we encourage you and hope that you will register at ctac.org for those events. And before we turn it over to our presenters, I just want to take a quick minute to introduce them to you. So Arms Acres, we have Tammy Bender and Eric Dentrone. Tammy working in the field of addiction services for over 15 years, and she's been part of the Arms Acres and Conifer Park regional teams for the last 4 years. She's also the alumni coordinator for Arms Acres. She's a certified addiction recovery coach and a certified recovery peer advocate. And is currently supervising the 2 recovery coaches that Arms Acres has hired as part of the innovation grant that they received through the Hudson Valley Collaborative PPS. And is also from Arms Acres and Conifer Park, where he worked for the past 12 years. He's been working in the field of addiction services for over 20 years. He's the regional services team at Arms Acres and Conifer Park. And as I like to say, Eric is the point person for all things disrupt. And he's been managing the MHVC pilot program that they're going to be talking to us about today. And finally, we've got Doug Hovey with us. He's the founding executive director of Independent Living, Inc., and that's a consumer-run advocacy and service organization in the Mid-Hudson region. Champion the cause of equal rights, access, and opportunities for all persons with disabilities. And he's led the development of several progressive peer-based services that support the rights, rehabilitation, and recovery of individuals with physical, psychiatric, substance use, and developmental disabilities. So welcome to all our panelists. I also want to welcome Eve Addison, and he's going to be moderator for our discussion today. He's been in the behavioral health field for over 20 years in both residential and outpatient services, and a great colleague of mine. So welcome to all of you today. Just take a quick minute. Thanks for joining us and for part of this lively discussion. So what's going to happen is each presenters are going to take a few minutes and describe their programs and what they're doing and their innovations, and then we're going to have a facilitated discussion and, of course, leave some time at the end for questions and answers from our attendees. So please don't be shy and feel free to type in your questions through that box. So I'm going to advance our slide, and I'm going to pass the ball over to you guys, Tammy and Eric.
Daniela. And good afternoon, everyone. My name is Eric Dentrone, and I'm the Associate Director of Regional Services for Arms Acres in Conifer Park. Dan, thanks so much for that introduction. I think you pretty much covered it. So we can move right into the meat of our discussion. But just thank you for the opportunity, for giving us the opportunity to share while we've been with peers with the groups, so we really appreciate that. So just to give what we're doing with peers some context, I think it's important at least to describe who we are so everyone understands what service we provide, and then how peers fit into that. Arms Acres in Conifer Park, we're licensed by New York State OASAS. We're inpatient and outpatient substance use treatment provider. In Carmel, so in the Mid-Hudson region, we have 183 beds. As you see there, we have detox and rehab, 2 levels of care under one roof. We have med-supervised withdrawal and stabilization, and short-term rehabilitation. A multidisciplinary treatment team. We have nursing 24 hours a day. We have physicians. We have medical staff, psychiatry. It is almost like a hospital, just so people understand the level of care that we provide. We do have a detox services, so we're stabilizing withdrawal symptoms with medication, and also co-occurring medical and psychiatric symptoms. I'm just going to move through this as swiftly as possible, just so people see the scope of our services, the breadth of our services, and our inpatient rehab side. All of these, of course, will be available to you as they're archived on the MCTAC site. Important. Who do we work with? Who is our patient? Our patient are people who would be otherwise unable to have their SUD, substance use disorder, symptoms met in a lower level of care. So they need to be in a 24-hour setting to become stabilized. Some examples would be people experiencing moderate to severe withdrawal, needing some medical supervision. They also might have co-occurring psychiatric symptoms. In fact, most of our patients would have co-occurring psychiatric symptoms or diagnoses that are not being addressed when they're out there, when they're using this. And so they need stabilization on multiple domains. They also tend to have chronic medical conditions that also need attention, like diabetes or hypertension or infectious disease. So that gives you an idea of who we're working with. What I'll also say is that we're working mostly with patients who are recipients of Medicaid. So we're working with largely the Medicaid population. You also have social determinants of health that could be impacting their ability to stay on track. A lot of our patients have issues with housing, with community tenure, connection to primary care, transportation, food, poverty, etc. So it's the complex cases with complex clinical symptoms that need attention in a lot of areas. So that's just to our Innovation Fund project, which we entered into a year ago. We were looking at the transition of care from patient to outpatient. And baseline, as you see, with the top of the slide there, the rate at which our patients were keeping their first aftercare appointments in the community was less than half, 0.77%. We wanted to get to really address that. When people leave inpatient to outpatient, that transition of care it's a critical time, and it can really set everything on course in terms of people staying on track and connected to care, or not being managed and things escalating, and they end up back in an emergency department or becoming hospitalized again, or back in inpatient with us or other providers. So it's a really critical point that it's a gap that we identify that needs to be filled. And really, it is, in the midst of an opioid crisis, it's a life or death situation. Been documented cases, lots of being paid to people coming out of institutions, whether jails or hospitals or inpatient facilities, by a risk of overdose, of course, with the advent of fentanyl. And so it's really a life or death time. So it's a critical point that needed attention. So we wanted to see if we could have an innovation project that would address that gap. And we proposed an idea with Montefiore Hudson Valley Collaborative, an innovation fund, to hire 2 recovery coaches who work with our patients as making that transition. I'm going to pass it over to my colleague Tammy Bender, who will describe what the coaches do.
Hi, thank you, Eric. And thank you, buddy. I'm really excited to be a part of this panel today and to share with you what we're doing here at Arms Acres with our recovery coaches. There are criteria that we've established for the case managers to review when they're going to refer what patients refer to us for recovery coach services. So they have to be on Medicaid. They have to live within the 7 counties of the Hudson Valley. They have to be at high risk for relapse. And what's great about it is that the coaches can actually meet with the patients while they're still here inpatient, and creating, developing a relationship, getting trust of the patient prior to them being discharged, so that when they do leave, they're more likely to stay in contact with the coaches. So provide a lot of services. One of the most important things is making sure that they're getting to that first outpatient appointment. They meet with them at the outpatient appointment, and they meet with the case managers. They get all the consent signed and all that, and that's a really critical piece. Again, they follow through with the second appointment and all the other things. The thing that they do that I think is really important, a lot of our patients, there's a lot of different challenges that they have going on. So they need to go to social services for different services, emergency housing. They have court cases pending, and the coaches will go with them, help them through all of those processes, and really supporting them in an area of their life that they need, was so important in early recovery. Pass it over to Eric, and he's going to talk more about the data and that piece of it.
Thank you, Tammy. So let's get right to the outcomes in terms of what we've seen so far with this project. So from January 1st of this year to July, actually end of the month, July 31st, 2018, we had a total of 85 recoveries that have worked with our recovery coaches. And total for our show rate, I guess you would say, for the first outpatient visit, these recoveries have kept their appointments at a rate of 98.2%. So more than double our baseline. It far exceeded even our expectations. So one of the other things that we were looking at, which is an important with value-based payment, is how many of those are happening within 7 days of discharge. And out of those, 85, 68 kept their appointment within 7 days of discharge. And a lot of that was because of the connection to the peer, the connection to the coach. Sometimes we missed appointments, the coach would help them navigate that to get that other appointment and really make sure that happened quickly post-discharge. And the thing that had evolved as part of this project, we wanted to really start to look at engagement, not just we move the needle on that first appointment, but the second appointment, because it's our belief that that would be a good indicator of, is the person engaged with that program. A lot of times, the agency that's making the referral owns that motivation and everything they can to make sure that patient gets to that first appointment. But we see if having a coach might impact the second appointment, and do they stay, and do they come back to that for that second visit? And they did at a rate of 84.11%. One of the things in terms of improving engagement, we're looking at 30 days. Are they still staying in treatment at that outpatient provider post-discharge? 30 days post-discharge. And so there were 73 follow-up calls made that same time period from January to end of July. 57 people still engaged with their treatment provider after 3 days post-discharge from arms acres, a rate of 78.08%. A really, really good indicator that the person is engaged in their treatment program. From here, starting to look at the next steps. How does this value-based payment? Starting to look at cost avoidance. That's the next phase of our project here, where we see it going forward. We see, to take a look at and measure how many of our recoveries needed to be readmitted to inpatient substance use treatment, whether with Acres or other providers. How many recoveries had to go to visit an emergency department in the last 30 days? How many recoveries required hospitalization, either for medical treatment or for psychiatric treatment? So we think with this data, if we compare that data with regional and state data, we'll be able to have a better understanding of the return on investment. So then we could then, for example, go to peers and show the value that this project would have and adds to our services. And I think that that is it for us. Yes, and I'm going to pass it over to Doug. There we go. And Doug, you have the ball.
Well, thank you very much, Eric. And thank you, Daniela and Eve, for the opportunity to present today. This is an exciting opportunity, and it's nice to partner with Eric and Arms Acres as well. So a bit about myself and independent living, a little background and history. My name is Doug Hovey. I'm the executive director, founding executive director of Independent Living, Disability Advocacy and Disability Service Organization since 1987. And started with 3 employees in 1987. But I just want to emphasize the fact that peer services, or peer counseling in particular, is one of the independent living core services for all the independent living centers. So that's always been something that's been foundational for us. Not all independent living centers are as heavily invested in substance use and mental health peer counseling and peer advocacy and peer supports. We found it critically important, particularly in our community. All independent living centers are sort of defined by the unique needs of their respective communities and the interests of leadership. We opened our doors in 1987. It became quickly evident. Not only did I have a personal interest and a personal reason for wanting to be strong in peer mental health services, I also realized quickly that about 60% of the folks who were knocking on our doors for assistance were people who had a diagnosis of either substance use or mental health, or a combination of both. So, again, early on in 1987, 88, we were really getting heavily invested in outreach and engagement strategies and providing support systems and learning as much as we could about self-help modalities. And, if you're familiar with the independent living philosophy, it's nothing about us without us. It's very invested in consumer-directed services. 1993, we had the Reinvestment Act, passed the Investment Act in New York State, and as a result of that, we were fortunate to get funded through the Orange County Department of Mental Health and the New York State Office of Mental Health. And we've always had tremendous support from our local county Department of Mental Health and our commissioners there. Darcy Miller is our current commissioner today, who she just fully understands the importance of peer services and how invaluable they are as a complement to the mental health response system here in Orange County. So we've been very fortunate for that. In the early 90s, we started engaging folks over at Middletown Psychiatric Center, which ultimately closed around 2006. I'd love to say that we were responsible for that closure, but the truth is the state leaders and the community saw it was time to help support people and move them into the community. We did work very carefully with many of the individuals doing transition and diversion or bridger services, if you will. And so sort of on the heels of that, we realized that the peer bridger model was an effective model, and we could apply that model to the local behavioral health units, the short-term stay hospitals. And I'll talk a little bit about that in a minute, but I have to give credit to NIAPRS and Harvey Rosenthal because the bridger model really, and the bridger term was really created and defined by NIAPRS back in 1994. To the best of my knowledge, they were the first to introduce peer bridger services. And we saw that model as being effective in the long-term stay hospitals and decided that we would implement that same model at the local behavioral health units now that the long-term psychiatric center was closed. So we've had very unique partnerships with 3 hospitals in particular. One was the Cornwall Hospital, which since closed. That behavioral health unit has closed. But now it's Orange Regional Medical Center and Bon Secours Community Hospital and Catskill Regional Medical Center. So we're actually very well invested and provide services on those units in partnership with the clinicians on the unit. But I want to mention that we're not supervised by the clinicians. It's a unique and complementary relationship that we have in partnership with the hospital staff, and other community partners. So that's very important for me to mention. A lot of our services are invested in consumer direction, as I said. We also have a consumer-directed home care division that employs 780 home care workers in our region. The consumer-directed model essentially means that the individual receiving services is in charge of the recruitment, the hiring, the training, the managing, and the firing of, if necessary, of their actual workers. We also have the self-directed care model, which is funded through the New York State Office of Mental Health. It's a pilot project. We're one of 2 sites in the state to introduce this concept where individuals can get a budget that is used in connection with some recovery outcomes or intended outcomes. So they can get anywhere from $8,000 to $16,000 if they're HARP eligible, and that's the requirement. They have to be HARP eligible to be a part of a particular project. But that's another self-directed program we have. We also have a self-direction program for people with developmental disabilities, consumer control. We have a regional project in partnership with the Mental Health Association in Rockland County and People, Inc. in Dutchess County. It's a multi-county partnership called Reach One, where we have a few different contracts that allow us to hire peers in each of these respective counties. And it's a collaborative project where we do share some of the backroom operations, but we share in data collection and share in our training opportunities. So there's an economy of scale by regionalizing this and creating this type of a strategic alliance or partnership. Last year, we received funding through OASAS to create a recovery community outreach center, and we have 5 full-time peers who provide outreach and engagement in connection with area hospitals and to provide support to people who are looking for recovery from substance use issues. Most recently, or in the last year, we have developed a partnership through the PPS. The Westchester Medical Center has been a great partner, and we have developed a project at Bon Secours Community Hospital in Port Jefferson. And it's a unique and new concept where 3 partners are dedicated to the efficient transition of folks from the behavioral health unit back to community to support them so that they are stabilized and have what they need to sustain in the community and not have to return back to the behavioral health unit. The partners in that project are Westchester Medical Center and the clinical team at Bon Secours Community Hospital. Our team of peers, 3 full-time peers dedicated to this particular project that work in tandem with the clinicians on the behavioral health unit, designing discharges. The beauty of the project is that our peers can literally execute or support individuals in implementing their very specific discharge plan back to the community. Our third partner is CBHS, Coordinated Behavioral Health Services, which represented by several organizations in the region. Most specifically, our partner is Access Supports Living. They do a 48-hour follow-up after we transition an individual back to the community and support them and get a lot of their social determinants of health issues addressed. Access Supports does a follow-up 48-hour clinical assessment, check in, make sure that the folks are doing well, and to really do another assessment of what their needs are at that particular junction in their transition and recovery process. So that's been an exciting project. We're just entering into year 2 in that project, and we're showing some significant positive outcomes. We've had over 90% success rate in keeping people from returning to the hospital, at least for 30 days or more. And connecting people to other critical resources is one of our goals, and we've been highly successful at doing that. I'd like to mention that in 1997 was actually the very first year we received dedicated funding from the Office of Mental Health in order to set up our peer bridger services at the local hospital. So, we've been doing this for 21 years, and so we have what we think is a well-refined system And you have to keep in mind that peer services comes in various different forms. And we're going to get to some specific questions about the types of skill sets that we look for when we're recruiting for peers to work in our various different types of peer programs. Okay? And I think I'll stop there, and we can move on to the next.
Daniela, I'm up now. This is Eve speaking. I have to say that all of you provided with a good deal of information, and I want to remind everyone that the slides will be available, and you'll be able to see more detail on that. So what I want to kind of begin with is, in your descriptions of your programs and your innovations, there's an assumption that lived experience is an important dimension of the success that you both achieved in services you provide with the people that you serve. I'm wondering if you could kind of address what other skills do effective counselors have these experience that promote successful engagement with the people served? Can you take, Eric or Tammy, can you address that?
I can. It's this Tammy. Yeah. I would say self-care is one of the important things, making sure that the peer advocates are taking care of themselves. They're still going to the self-help, doing all the things that they need to do for their recovery. Empathy, being empathy for the people that they're working with is critical. Time management is a very important piece if they do. And also making sure that they're aware of all the resources that are available in each of the counties that they work in and learning that work effectively.
What is it that how would you answer that question?
It's a good question. And, when you're looking for different types of skills, from perspective, because we have different types of peer roles, we look for different skills within each of those roles. For example, if you want to be a peer advocate and work in an office setting with scheduled appointments or folks may drop in for assistance and support, that might require a slightly different level of skill than if you're working on the behavioral health unit, proactively engaging people who are in crisis, or if you're like our first responders, peers that actually go out in tandem with the mobile crisis team in Orange County. But I think it's important, number one, that in addition to being a peer, being a spoken peer, being able to comfortably use your experience, your personal experience, your life experience to help other people. And you have to be comfortable in talking about that. You've got to be able to proactively engage people. Motivational interviewing is so essential in the peer engagement services that we provide. You've got to be a good listener. And then, of course, there's an extensive list of trainings that we provide. Once we hire peers, they have a certain amount of time to achieve a certain list of credentials that we expect them to have, different types of trainings. And I think you have to keep in mind that, peer services is not, it's still a relatively new field, although we've been doing it for many years, but it's really just sort of exploded within the mental health and substance use industries. So it's not like there's hundreds of certified peers out there who are lining up for jobs. So we're still doing a lot of work in workforce development, helping to create more peers that are available and are seeing this as an opportunity for climbing a career ladder.
Okay, let me go to sort of another part of this whole approach, which is training. I'm wondering, do you guys have a training curriculum for your peer counselors? Do you have one, and also is it different from the curriculum you have for non-peer staff? who wants to take that first.
For our bakers, we requested that each of our recovery coaches be certified, a certified recovery coach, and shortly after that, to be the certified peer advocates as well. And there are ongoing trainings for New York, SAMHSA, there's a lot of different trainings available throughout the year that those are attending to keep up with the change in the field.
Is there anything sort of particular to peers that you have, or does everyone in the organization, all the direct care providers, are they all expected to participate in the same curriculum?
Well,
other than the peer specialist part, but all the other things that you mentioned. What I'm going to get at is, and for our audience, is there anything in particular that you want your peer staff to have that's different from the other practitioners?
For recovery coach and the CERPA certification.
Okay.
Yeah.
Okay. And Doug, how about you?
Yeah, we do require certain trainings that are very specific to our different peer roles within the organization. Let me back up a little bit, Eve, and tell you that a lot of our initial orientation and training about the organization, about the culture of our organization, about the values, and about a process that we use called continuous development of people process, that training is universally applied to all of our employees. But when we get into very specific discipline types of trainings, on the peer side, we do require the certification process through the Academy of Peer Services for all our peers. And sometimes people don't come with that. So we have a time frame in which you have to actually have completed that. Trauma-informed care is another training that is critically important, and we make sure our staff have those trainings. Motivational interviewing. There's a tool called the DLA 20. It's a daily living activities assessment tool. We think it's an effective tool. Orange County is embracing, adopting use of the DLA 20. We also provide safe talk, suicide prevention training for our peers, and wellness and recovery action planning is another training that we provide. Mental health first aid is another one, and for our WASAS staff, they do become certified recovery peer advocates, or they get the CERPA training. And our hospitals that we partner with require us to take certain trainings through them. And I remember years ago when they first introduced this, I thought, wow, this is really clinical stuff. But it's important that our peers understand where the clinicians come from so that we can have a meeting of the mind. So all of the hospitals that we work with do have certain specific requirements for training. And then our SMART recovery and refuge recovery group facilitation trainings are important for particularly our substance use peers that work for us.
Can you say something more about the continued development of people training or approach? What is that? I think our audience, what is that exactly?
Sure. CDPP, as we call it, is really working one-on-one with your staff in developing a very specific set of goals that are going to support your growth and development within the organization. And I know it was mentioned earlier, self-care is such a critically important part of staying well. This is tough work, particularly when you're dealing, providing proactive engagement every single day. So we talk about self-care as being a part of the goal to support each of our peers, but we also look at other specific goals and outcomes that are reviewed on a quarterly basis. And we actually use this as a performance evaluation tool. So rather than using traditional performance appraisal systems, we use the CDPP process. It seems to be very effective. It's helped to change our culture here. Something called the white flag feedback system, which has helped to reduce issues that may arise in the organization. And white flag feedback essentially just means that if you have an issue with somebody in the organization, you knock on their door and you have a private conversation, and you always try to resolve it at the least, the lowest level, so it doesn't fester into something. And it's an open, honest, trusting type of culture that we've created as a result of introducing the CDPP model, and that's critically important when we're including people with all types of disabilities as a part of our workforce.
So if I understand it, CDPP is something that is sort of integrated into supervision, right? It's the supervisors. People who supervise the peers are actually doing this work in collaboration with their peers. And then, and is this something that sort of published, sort of something that if our audience wanted to kind of get more information on CDPP, is it something that's available? Like, you know, could they Google it on the internet, or is it something particular to independent living that you created?
No, this is available. We work with a consultant out of Connecticut by the name of Wally Hauck, H-A-U-C-K, and he calls it CDPP, but he also calls it CPIP, Continuous Process Improvement Plan. So yeah, you can Google him. He's been wonderful for really helping our culture to become more open and transparent and supportive.
Thank you for that. I think that, that's an important resource that people listening to this may want to consider. All right, so moving into this whole notion of, you know, hiring people, providing them with training, supervising them in a way that helps them to develop as practitioners and to really thrive in the field. What do you do for folks regarding career advancement? So you hire people at an entry level, and you provide them with all these supports, and you provide them with supervision. You have an adequate ladder for increasing people's responsibility and wages. And I'm asking this of both organizations, although I know, Doug, you know, you've been doing this longer. I'm just wondering also if Eric and Tammy, if you've given thought to this in terms of your peer workforce.
Well, as you mentioned, Eva, you know, we're very nice, and
right.
You know, Doug's and his organization, they have just a depth, wealth of experience, and we are just kind of learning this ourselves. And so early on in the process, really in its infancy, I mean, it's been less than a year that we've had peers as part of what we do. So, you know, there certainly are pathways. People can certainly get the training to ascend over into the clinical side if they chose. In terms of into case management work, you know, if they were to attain their case or a social work degree, they could move over to the clinical side. But there we are right now. Tammy, do you have any?
Yeah, again, because we are so new, obviously it is something that we would like to be able to offer forward, but as of right now, no.
Okay. Doug, how about you? How do you sort of address this issue of career advancement, wage increases and all that?
Right. And, you know, as the CEO of this company, that's always my responsibility to make sure that we are continually creating opportunities for all of the employees in our organization. And so I want to just start by saying that the fact that somebody is a peer and they have lived experience and they're comfortable with sharing that, they're a spoken peer, we quickly view that as an credential, and we always have, you know. How many employers, when somebody tells you, I'm in recovery for, 5 years from substance use, how many employers go, yes, well, we do. We see that as an awesome, it's a credential that we look for, or people who are in recovery from a mental health disability. So I want to just mention that first and foremost. So we do our best to recognize that as an added talent, and we hire people. We're really doing our best to get our salaries in a respectable place, recognizing the talents of peers. They're not just add-on staff. They're not extensions of a clinical practice, and they're not assistants to clinicians. They are peer professionals, and we're doing a lot to help elevate peers to a respectable level. And I think that we're seeing evolution happen as a result of that. But right now, we have 6 different positions and levels of career opportunities here at Independent Living. And one is, you start as a peer advocate or a peer counselor, and then you may work in the area of peer hospital diversion or bridger services, which is a slightly elevated function and role, and along with going out first response on the mobile team. So we do our best to start our salaries in the high 30s, and we're really struggling to get the base salary at 40. But then there's the next step. It would be you could become a team leader, and we have a need for team leaders to organize different projects that we're working on where peers are actively engaged in the community. And then we have an assistant manager level, so we have peers that have actually gone through, have become a team leader and then have become an assistant manager. And then the next step is to become a manager, and we have several peers who are actually managers in the organization. And the next level would be director. We do have directors who have come through the ranks of peer services and have climbed the ladder. And then finally, the 6th area would be a member of the executive team. So there's this continuous opportunity, and we're always evaluating the talent within our organization. And it's our obligation also to provide the appropriate training and staff development so that people do have an opportunity to grow beyond the entry-level peer services. And now, some folks choose to stay at that level, and they're fabulous at it, and we support that as well.
There are, for both organizations, are there, other than salary, other rewards or perks that you offer to make employment at your agency appealing to peer counselors? Take that one.
I don't mind if it's okay, or did you want to go?
Go ahead, please.
Sure. So, I think we have a generous benefits package for all of our employees. And again, we try to stay competitive with industry norms relative to salary, and we're even slightly above the industry norms in some of our peer positions, and I hope we are, because I think they're sorely underpaid and underutilized and not valued to the extent that they should be. We also have a 401k plan that all of our full-time peers are eligible for, and we have a 4% annual matching, so you can match up to 4% of your salary on an annual basis. We do have a generous vacation time off package. We have a sick time, personal time, and of course we have our annual holiday schedule, which is typically around 11 or 12 days each year. But, and I think reasonable accommodation will play into this also, because as an independent living center, as an organization who advocated for the passage of the Americans with Disabilities Act, we recognize the importance of reasonable accommodation in the workplace, and certainly we're very sensitive to times when individuals may need a little more support than others. So that's an important factor. And at the end of the day, I mean, you treat people with dignity, respect, and we emphasize customer focus, you get a lot. You get a lot out of your workers, and open, honest, trusting relationships with your people, direct relationships, creating expectations from the beginning, I think is essential too. If you see things that you don't think are appropriate for the work setting, relative to time management or interactions, you talk about them. And again, the white flag feedback system has been just an incredible tool for us because, we don't run and tell somebody else that somebody's doing something. We go and talk to the person in question, and we close the door. And everybody's receptive to white flag feedback, even me as the CEO. And I've been called into meetings with individuals to talk about certain things. So it has a lot to do with your culture and your benefits that you offer.
That kind of transparency, I could see, the results in a very open culture. Eric and Tammy, you have your peers working, as you indicated in your initial presentation, with a lot of other disciplines and licenses and practitioners. I'm just wondering, in terms of the audience, what you would recommend to help the peer staff integrate into this multidisciplinary workforce. Do you do things, or do you have a way of approaching integration, seamlessness of peers into the broader workforce?
Sure. And just to kind of dovetail on what Doug was just saying, and I think kind of is part of what we're asking now as well. Having the peers be part of helping move the ball downfield, so to speak. Like this is new to our treatment field in terms of integrating peers into treatment to complement treatment and to complement clinical work being done. So I think in terms of appeal to the force, in my opinion, I think it's exciting to be part of that change. We wrote to our recovery coaches. We asked them continually it's bidirectional communication. We asked them for feedback. What could be different? What could we try? So I think that has been an essential part of how we've gotten to this point. Integration with our clinical team, we were strategic, I think, from the beginning, in terms of making sure that it was set up right. There was a foundation there of understanding of what their roles would be, how it flowed with the work that was already being done. So we did some training with our staff before we even hired the coaches that this is what we're doing. So they begin to understand and kind of think about that. And then once the coaches were hired, introducing them to staff, making sure that their roles were clear. When is a referral to the coach appropriate? How can it be done in the most efficient way? And then to the larger community, we also from the beginning made sure that we introduced them in person to our partners, to those treatment providers throughout the Hudson region that we were bringing our patients to, so that they knew exactly what the coaches were, because it's new. It's a really new thing. And I think that helps kind of set the tone and the foundation. Everybody was on board. Everybody was very supportive in terms of our community partners. At the outset, they understood how it helped them do the work that they do, how it could help them in terms of like retention and engagement on their side. So everybody wins. I think that was an essential
right.
piece to that.
Right. I think I'd like to say.
Go ahead.
The other thing I'd like to add to that is the clinical staff here have a treatment planning meeting every single day. And I go to that on a regular basis so that the lines of communication stay open. If there's a patient who's going to be discharging, if there's issues with them, we're constantly communicating with the clinical staff, making sure that we're giving the best care to the patients moving forward.
So this is sort of promoting a team approach where the peers are an essential part of the team to make decisions around care.
Correct.
And have you met any challenges with that? Or in terms of, I know you haven't been doing this for a long time, but has it gone smoothly?
For this part, initially, there's always a few in the clinical field that really had a understanding of the recovery coach services and thinking, it's just a phase. But now that they're seeing the results and the positive direction that more receptive now.
Okay, that's great. Okay, in the interest of time, I just have one last. I think, can we have one more question, or should we stop here?
Actually, Eve, I was hoping that you would have one last question, and that it would be your last question on that list that you and I talked about.
Okay. So this is the last question I'd like both organizations to respond to. This is, in a few sentences, if you could just tell us what your pitch would be, MCOs or other payers, as an introduction to the value of peer services. In a few sentences, what we say to a potential payer who may want to contract with you, what would you say in a few sentences the value of peer services? Why don't you take it first, Doug?
Sure, thanks, Eve. That's a good question. It's an important and timely question, too, as we're engaging the managed care organizations around introducing peer services. I would say that they should contract with peer service organizations. If any organizations that they can begin to develop relationships with, I think makes a lot of sense. Primarily, because I think as peer-run organizations, we really, that's always been our philosophy, is to help people not only stay out of the hospital, but to avoid high-cost services. Things like, and we're not opposed to services like care management or PROS or clinic or partial hospitalization, but oftentimes we can avoid having to go to that extent in the service delivery system. We can help to redirect folks and get them supported in a community with more natural supports and avoid high-cost services, again, not just hospitalizations. So I think that having peers with lived experience who are well-trained can really produce exceptional outcomes, and I think there's a lot of new data that's developing, and we're certainly producing excellent outcomes that we'd be more than happy to share as we continue in our different projects, but I think you're seeing tremendous outcomes from peer-based organizations. And the introduction of peers in a collaborative fashion. I think other clinical organizations should also consider reaching out to peer-run organizations for support and the introduction of peers into their clinical service models.
Hey, Tammy, what would you tell a potential payer who may want to? Actually, you're kind of doing it with your project, but assuming that you were just giving a new pitch about the value of peer services in a few sentences, what would you tell a potential payer?
Sure, and I think Doug said it well, but just to add to it, it really is about outcomes. When it goes to a department or someone goes to a hospital, somebody requires inpatient treatment for psych, and then of course this is the whole goal of just to avoid these high cost services, as Doug mentioned. Although all of that can be quantified, it can be projected. You can come up with an aggregate figure of what the average patient, who has substance use disorder and other complex conditions, what does it cost per year? Assuming that at certain rates of rehospitalization. So therefore, if you introduce something that's a lower cost, intervention and recovery coaching and peer advocates, way lower cost than, of course, a hospitalization. It's money well spent. It's avoiding high cost. It's with something that is something that's because the outcomes show that they work.
So for both of you then, and this is just to sum up, it's important to have data, demonstrate effectiveness, to demonstrate efficiency, and to make a successful pitch to payers so that they begin to appreciate that peer services are not only good for the people who are being served, but they're very good for the general cost savings in healthcare. Okay, thank you all for this discussion and for your very, very helpful contribution. And I hope that our audience has taken lots of notes. And again, thanks for doing this.
Guys, we did have a few questions that were typed in, and we have a couple minutes left, so I'm going to try and get through a couple of these with you. So the first is an easy question for you, Doug. What is CDPP? What does it stand for? One of our listeners was asking, I guess they wanted some more information on that.
Sure. It's continuous development of people process. And we were introduced to this in 2009 by a consultant by the name of Wally Hauck, H-A-U-C-K, he's right over across the border in Connecticut, but is doing quite a bit of work here in New York. So that's continued development of people process is really taking an active interest in your employees throughout your company to help them develop the skills that they need to be the best that they possibly can be within the organization and even personally speaking. So it's done great wonders for our culture here at Independent Living.
Cool. This next question is for the Arms Acres group. So this person is asking about how the SERPA peer program model works with health homes, HCBS, and other collaborators so they're not duplicating work.
An excellent question. I mean, there are a lot of sometimes the roles can be blurry. I think one is not meant to take the place of another. So I think it's down to like our coaches really knowing what their role is, and that if it becomes about coordinating care, to connect a person to a health home. That is not their role. It's also they're not clinical. So HCBS, community-based treat that way that's not their role either. So knowing who you are and knowing who you aren't, and knowing at least as Tammy mentioned before, like who the resources are out there to connect their patients to. There's no reason why they can't have both. Anything?
The last question is actually for both of you, because this will be our last question as we're out of time. But our listeners are asking about where they can find any information on the demonstration outcomes. Is anything available yet for you guys over at Arms Acres, and where they can find that info, and also for you guys over at Independent Living?
I'll start then. We have not published our results, but we do have data specific to 2016, 2017, and for the first 3 quarters of 2018, specific to our work at the behavioral health units, Orange Regional Medical Center, Catskill Regional Medical Center, and Bon Secours Community Hospital. But nothing published as of yet.
Yeah, we'll soon be wrapping up our year-end report with Montefiore, putting together all of our statistics, but it has not been published publicly.
I have a question. Once you do that, would you put that on your website so if people want to outcome data that could get it from the website?
Honestly, we haven't yet. So
okay.
we're figuring out as we go, but we've had those discussions yet internally. But we might do that.
Okay. I don't have that, your data, even though it's not published, sort of to the public. You don't have that data on your website.
We include in our value proposition, and that's evolving all the time too.
Okay.
In fact, I had just received a new data report yesterday that's not included in our most recent, but no, it's not on our website as of yet.
Okay. Thank you.
To all of you, especially our presenters, Doug, Tammy, and Eric, appreciate you guys taking the time. That's pretty much all we have time for today. So thanks again. And part 2 of our series, please stay tuned and tune in October for the next of solutions that work. Thanks so much, everyone. Have a great
Thank
day.
you, Danielle.
Bye.
Danielle, thanks, Eve.
Bye.